The implications in terms of potentially having gene transfer in the clinic are very multi-layered in terms of the different perspectives you might want to consider. One would be who is in fact eligible once this is approved, and this is going to depend on payers and others who make these decisions in terms of access, depending on the global context. But we have a concern that certain genotypes may be at higher risk for having tolerability issues, which would preclude treating those patients currently until we can better understand how to mitigate those potential risks. The trial programs have very clear exclusion criteria in terms of certain genotypes not being eligible. All of them have been doing this, but they're different depending on the microdystrophin product, so it gets very confusing. The next piece, of course, is seropositivity for the viral vectors. So we're not all using the same viral delivery mechanism. If you're AAV9 positive, perhaps you could get an RH74 targeted treatment safely, but not an AAV9 targeted treatment. AAV8 is also now starting to be used by a couple of the sponsors. So it depends on which virus you're using, whether someone may have an issue with seropositivity and both efficacy and safety implications of that. So until we learn better to modulate the immune reaction to allow seropositive people to be dosed with these approaches, that's going to be an issue in the clinic. And then the actual logistics of delivering this to perhaps large volumes of people who have multisystemic involvement from their Duchenne muscular dystrophy is going to be different for very young patients if we get newborn screening in place, those who are ambulant, which are the ones that are tending to be targeted with these protocols right now. The sweet spot for the biomarker side tends to be around 4 to 8 years of age, so that group is very biased in terms of having the most information about them. But of course, we want to be able to do this for those who are older living with dystrophinopathy also, if it's possible and safe. It's just the issue there is that they're having more and more involvement of the other systems from their disease, be it cardiomyopathy, respiratory failure, kidney involvement, other aspects of the disease that we know are there in the natural history. Does that make them more vulnerable to these potential complications of treatment? And if so, who might be at too much risk doing this to actually justify the potential benefit? And what is a realistic efficacy expectation when a lot of your muscle has already been replaced by fibrotic tissue and fat? Could we still make a meaningful impact in the experience of the rest of the disease for that person to counterbalance the risk involved? And then the last piece, which is always really ethically difficult to talk about, is this is probably going to be very expensive and logistically difficult to do for hospital systems. And where is the line in terms of when we can actually offer this to somebody living with Duchenne relative to the expected benefit for their contribution to society as a whole and the healthcare system economics of it, which is very challenging to think about with your individual person that you're making this decision for as a clinical team in conjunction with the family and with the person living with the disease if they're developmentally at a point where they can participate in the decision. But that conversation is very nuanced and involves a lot of more regulatory and economic and other factors to be considered also in the decision making around that, who actually would have access to treatment.